Patient vascular access is often limited. So in many cases, our only option is joining multiple infusion lines. As such, it is hard to completely avoid having dead volume in many IV setups we may encounter. In Part 1, we introduced dead volume and discussed how it has the potential to significantly impact the safe and timely delivery of medications. This module will continue this discussion and talk about steps we can take to limit dead volume's impact on our patients. To start thinking about dead volume again, consider the following event. A 66-year-old female patient was admitted to the emergency room with aching chest pain, elevated heart rate, and high blood pressure. They have been experiencing chest pain for over 2 hours. The patient needed her blood pressure brought under control and medication to slow her heart rate while she underwent diagnostic tests to assess the condition of her heart. The patient had a peripheral IV running at 15 milliliters per hour, and a dose of sodium nitroprusside was prepared and connected to the Y site of this line, as shown in the image. The sodium nitroprusside was started at 4 milliliters per hour. After 5 minutes, and no effect on the patient's condition, the caregiver increased the rate to 8 milliliters per hour. After another 5 minutes and still no effect on the patient's blood pressure, the caregiver increased the rate to 10 milliliters per hour. A minute later, the patient was suddenly dangerously hypotensive. Dead volume and its implications for delivery are what led to this situation and many others like it. Think about this event as we go through this module and how the outcome could have been mitigated. At the end of this module, we will revisit this case. The size of the dead volume is one element that influences the impact of dead volume. Reducing the size of the dead volume will decrease the duration of the delays and variations in delivery. We can reduce the size of the dead volume by being aware of how we join infusions together and carefully selecting IV components with small volumes. The volumes of the components, as dictated by their length and bore, are often labeled as the priming volume on their packages. Some IV tubing sets include a Y site or injection port close to the patient. Joining infusions at this site can result in considerable dead volume and should be avoided. Connecting infusions using a multi-port connector can reduce the dead volume considerably. Multi-port connectors are sometimes also referred to as a manifold, bridge, or multi-lead connector. Different multi-port connectors will have different volumes, and we should be selecting a connector that has the smallest volume that will permit flow at the flow rates you will require. There are many variations of multi-port connectors, and those shown here are just a couple examples. Avoid chaining multi-port connectors together, as this increases and complicates the dead volume. A stopcock can sometimes be used to serve as a small dead volume connector when you need to join two infusions. However, manually chaining stopcocks in sequence is not recommended. Joining stopcocks in this manner is prone to unintentional disconnections, cracks, and leaks. When joining infusions, the pathway to the patient should be as short as possible. Typically, this means joining the infusions close to the hub of the vascular access device. Avoid using any sort of tubing extension sets after the point where the infusions join, as this will drastically increase the dead volume. If you need to extend the IV line, use the extension sets prior to the multi-port connector. You can also reduce the dead volume by selecting IV tubing sets that have a small bore or internal diameter and a short length. There are standard, mini, and micro-bore tubing sets. Micro-bore sets have a very small internal diameter, meaning their volume is only a fraction of standard tubing sets. As such, mini and micro-bore tubing can help create setups with reduced dead volume. However, small diameter tubing may not permit flow at high flow rates, drug bolus rates, and the flow of viscous fluids. Before using mini or micro-bore tubing, ensure it will permit flow at the rates you will require. It is important that your institution test your tubing sets and provide information on the flow rate restrictions of the tubing. It is important to remember that the vascular access device also contributes to the size of the dead volume. There are a variety of different designs, each having unique volumes. While dead volume should not be the primary factor in your selection of a vascular access device, if your institution has some catheter options for you to select from, keep in mind its contribution to the dead volume. In summary, to reduce the size of the dead volume, use a multi-port connector with a small volume to join the infusions. Avoid attaching any unnecessary IV components below the point where your infusions join together. Use IV tubing with a small bore and length. While not the primary factor in selecting a vascular access device, consider a vascular access device with a small volume if you have several clinically viable options. Reducing the size of dead volume is recognized as a significant area of focus. Work is currently being done to develop new products, such as tubing sets and connectors, which result in practically no dead volume. Besides reducing the size of the dead volume, another way to minimize dead volume's potential to impact your deliveries is to strategically increase the flow rate through the dead volume. You can do this by using a carrier fluid. A carrier fluid can be used to help transport the medications through the dead volume, helping to quickly propagate changes made at the pump level to the patient. A carrier fluid is a non-medication fluid being delivered at a basal infusion rate. We attach it upstream of where multiple medication lines join together to help transport all the medications to the patient. A carrier fluid is particularly useful when delivering medications at slow flow rates or requiring frequent titration. The carrier fluid helps promote uninterrupted flow of IV medications and can also help maintain a patent line. Consider the time to clear the dead volume when we decrease an infusion from 0.7 to 0.4 milliliters per hour. Without a carrier fluid, the time to clear the dead volume for this would be over half an hour. Now, consider if we had a carrier fluid running at 5 milliliters per hour and made the same change. By having the carrier fluid, we significantly decrease the time to clear the dead volume. With a carrier fluid, it now takes under 10 minutes. The flow rate of the carrier fluid must be carefully considered. It must be set at a rate that will prevent delays in medication delivery following changes, while also ensuring the patient will not be receiving excess fluid. An example of one typical practice is for caregivers to increase the carrier fluid flow rate when the patient is unstable and critical drug titrations are necessary, and then gradually ramp down the carrier flow rate later when the patient is stable to achieve fluid balance targets. It is important to keep in mind that making sudden changes to the carrier flow rate will impact the delivery of all the other joint infusions. As such, gradually changing the carrier flow rate is best to ensure you do not impact the other infusions too much. We often need to be particularly careful about the amount of fluid critically ill patients are receiving. In certain situations, the amount of fluid a carrier would administer may be too much, and you may not be able to use one. In these cases, we must remember to take steps to reduce the size of the dead volume. We must also act with the knowledge that making a change to one of the connected infusions will not be immediate and will influence the other connected infusions. When using a carrier fluid, one important consideration is that since it often flows at a higher rate than the other infusions, we should avoid abruptly starting the carrier fluid after all the other infusions are running. Failing to do this would bolus all the medications currently in the dead volume at a fast rate. Try to establish your carrier fluid at the start of your setup and add your infusions to the running carrier line, or start the carrier at a slow flow rate and gradually increase the flow rate. One other way to help reduce the impact of dead volume is consider the order in which you connect infusions. Some multi-port connectors join all the infusions together at a single point, while others slightly stagger the joining of the infusions. These linear manifolds that stagger the joining of infusions mean there are short segments of dead volume that contain slightly different mixes of the medications. The infusion joined at the most upstream port will have the most dead volume, while the downstream port will have the smallest dead volume. Therefore, To minimize the dead volume for the most rate-critical vasoactive drugs, consider using the port closest to the patient if you are using a staggered port manifold. Even when reducing the size of the dead volume and using a carrier fluid to increase the flow rate, it is difficult to completely eliminate the delays and temporary flow rate deviations caused by dead volume. Sometimes the only thing we can do is to be mindful that these delays and deviations will exist following a change in a connected infusion and respond accordingly. Following a change, we need to be careful not to over-respond, given what we know about how dead volume impacts all the connected infusions. Upon making a change, if the patient's responsiveness to a drug suddenly fluctuates, we may need to simply wait until the dead volume is cleared. By attempting to respond to a temporary change in the patient's vital signs too quickly, we may end up overcompensating, prompting further fluctuations in their vital signs. Let's return to the event we described at the start of this module and see how not taking into account the dead volume leads to the patient becoming dangerously hypotensive. Here is a description of the event if you would like to review, before we zoom in and look at what happened in the dead volume. This setup has about 3.5 milliliters of dead volume. Let's visualize this dead volume as just a straight tube. When the sodium nitroprusside infusion was connected, only a dextrose solution was in the dead volume, moving at 15 milliliters per hour. Starting the sodium nitroprusside at 4 milliliters per hour increased the total flow through the dead volume to 19 milliliters per hour. At 19 milliliters per hour, it would have required more than 11 minutes to clear the dead volume. So, only 5 minutes after starting the sodium nitroprusside, we should not expect to see a medication response. It is not being delivered at its programmed rate. However, the caregiver was not aware of this. Figuring the medication wasn't working, the caregiver increased the dose by increasing the flow rate to 8 milliliters per hour. This will clear the dead volume faster, but it will still take at least 5 minutes to completely clear and reach the patient. After waiting another 5 minutes and still seeing no medication response, the caregiver then increases the flow rate to 10 milliliters per hour. When this change is made, the dead volume was on the verge of being cleared. When the patient finally started receiving the sodium nitroprusside a minute later, they are only just starting to respond to it when delivery quickly ramps up to more than twice the initially ordered rate. This leads to the patient becoming suddenly hypotensive. In this case, had the caregiver understood the impact of dead volume, they may have recognized that at 4 milliliters per hour, it would take a while for the sodium nitroprusside to reach the patient at that programmed rate. Rather than waiting more than 11 minutes for the patient to receive the medication, the caregiver could have taken some steps to limit this delay. One step could be to reduce the size of the dead volume by using a multi-port connector or stopcock near the venous access site rather than a Y site to connect the two infusions. Another step could have been to use the dextrose solution as a carrier fluid and temporarily increase its rate to push the newly started sodium nitroprusside through the dead volume. The dextrose solution could have then been gradually decreased back to its starting rate. In summary, we can limit the impact of dead volume by doing the following things. That completes both parts of this series on the essential considerations when dealing with dead volume. We hope it has been informative. To learn more about dead volume and how the implications of dead volume relate to secondary or piggyback infusions, we recommend you view the modules developed by Humanera for Health Quality Ontario, currently hosted on ISMP Canada's website.